ঠিক আছে।
Dr. Nilanjana, any news of Dr. Pritam Roy?
Yeah. Screen will be shared by Dr. Pritam Roy. Yeah, can you please come again? Can he share the screen?
Okay, I'm sharing the screen.
Should we start the program?
Yes, you can start the program, please.
Okay. So, warm welcome to all esteemed dignitaries. And as we are in this session of neglected tropical disease of the IAPSM West Bengal State Chapter, it is an extreme honor for me to be able to moderate this session. Thanks to the organizing team, organizing secretary, and the entire team who made this possible. We are here with our today's session. Chairperson of the session is Adhyapak Dr. Palash Kumar Das sir, who is a medical superintendent and vice principal of Rampurhat Government Medical College. With this, he is a well-known, renowned figure and a renowned public health specialist, and we are very lucky to have him as a chairperson for this session. Our first speaker is hello, Dr. Pritam. Our first speaker is Dr. Raman Veluadhan sir, who is MSc PhD and at present head of Veterinary Public Health, Vector Control and Environment Unit, Department of Control of NTD, WHO, Geneva. He is the global focal point for dengue prevention and control, integrated vector management, and coordinates other arboviral vector-borne diseases and control activities at WHO. In his present assignment, he also supports the Secretariat for the Vector Control Advisory Group. He joined WHO in 1989 and has worked in Solomon Islands, Fiji, Philippines. His field of expertise include malaria control, filariasis control, and control of soil-transmitted helminths and schistosomiasis. He is a recipient of the 2 awards for excellence from WHO. Before joining WHO, Raman sir worked for the Government of India at Vector Control Research Center, Pondicherry, WHO Collaborating Center, which is where his primary responsibility included evaluation of insecticides and teaching master's degree students of medical entomology. A warm welcome, sir. We are here to listen to your presentation. Our next speaker is well known to us. He is a dynamic, energetic young physician, come public health specialist, ever enthusiastic to ensure quality dissemination of knowledge. Welcome, Dr. Pritam Roy, a MBBS graduate from Calcutta Medical College, Kolkata. He completed his MD from New Delhi and was then in PGI, Chandigarh. Currently, he is with the World Health Organization and is heading the state of West Bengal. Besides authoring numerous chapters in renowned textbooks as well as MCQ books, he also has several publications in national and international journals to his name, and also the editor of National Journal and in framing and drafting national health documents for Ministry of Health. This amiable and modest doctor is driven by the constant support and encouragement received from undergraduates and postgraduate students alike from different medical colleges of India. This tech-savvy doctor is always available for his students. If you get in touch, mail him at his email ID. Welcome, doctor, and we are here to listen to your presentation. Thank you so much. Now the session is all yours. Now I invite our speaker, sirs, to please continue with the session. Thank you.
Thank you very much. Good afternoon to everyone. I'm Raman. So let me just load my first slide. Sorry. There is something wrong in loading my slide. Yeah. So I hope you can see this slide. I'm just putting it. Yeah. So thank you very much for this opportunity. And as you all know, that my talk is on the roadmap for neglected tropical diseases. Basically, we have a new roadmap starting from 2021 this year to 2030. As many of you would have already known, a lot of our activities are disrupted by current pandemic. And many of these targets will be further revised and realigned as we move forward. So basically, this roadmap is a high-level strategy document. It's a tool. It aids in advocacy. We had an extensive consultation approach with many stakeholders participating. There are very specific measurable targets, and the main emphasis is on a cross-cutting approach. As many of you know, we have a set of 20 diseases, some of which we are aiming for eradication, which is a permanent reduction to zero, elimination, which is to interrupt transmission, eliminating some disease as a public health problem, and many diseases are here for control. Basically, we are targeting controlling morbidity and mortality. So the NTD roadmap has several targets, and some of them are overarching, and many of these targets are also cross-cutting. So what you know very well that many neglected tropical diseases rely on preventive chemotherapy, so that we are targeting diseases which can be eliminated. So we hope that in the next 10 years, at least 2 NTDs will be eradicated, and over 100 countries would have eliminated at least 1 NTD. So basically, the number of people who needs an intervention will decline by 90%, and the DALIs also, there will be fewer NTD-related DALIs, which also we hope will decline by 75%. So from a cross-cutting target, we hope that 75% of integrated treatment coverage will be achieved. 40 countries will adopt and implement the new integrated skin NTDs. 90% of the population at risk are protected against catastrophic out-of-pocket payments. So essentially bringing in the concept of country ownership. There will be 100% access to water supply and sanitation. And of course, from the vector control point of view, we are hoping that we will achieve at least 75% reduction in vector-borne disease deaths. And of course, this is in close collaboration with malaria, which accounts for most of the mortalities in vector-borne diseases. So as you know, these are the diseases which we have targets. The countries we hope to achieve total eradication of dracunculosis and yaws in 194 countries. The ones which are targeted for elimination are human African trypanosomiasis, leprosy, and onchocerciasis. And then there are countries which will eliminate some of these diseases as a public health problem. And this includes Chagas, hat, leishmaniasis, filariasis, rabies, schistosomiasis, soil transmitted helminths, and trachoma. As you know, that there are many diseases which are still working towards control, and this includes Buruli ulcer, dengue, echinococcosis, foodborne trematodes, cutaneous leishmaniasis, mycetoma, scabies, and other ectoparasites. And one of our new entrant in NTD is the snakebite envenoms, and then the last one is teniasis. So all these 20 diseases have got clear-cut goals to achieve in this space of 10 years. So the NTD roadmap has got really three essential shifts. One is we are aiming to measure impact, and there is really an accountability factor at the country level. We are moving from vertical disease programs to more cross-cutting, holistic approaches. And then the last point is to bring in a partnership and funding and bring in program ownership with countries leading the way, and wherever possible with adequate domestic financing. So there are three pillars basically to accelerate programmatic approach. So the technical progress will continue, strategies and service delivery will be clearly earmarked and integrated wherever possible with adequate logistic support. And of course, there will be enablers like advocacy and funding with collaboration, including multi-sectoral action. There is also intensified cross-cutting approaches where we will integrate NTD wherever possible with other diseases. We are part of the universal health coverage. We coordinate with other sectors like WASH, vector control, and maybe to some degree even climate change, because there are climate sensitive NTDs. And the change in the operating model is that we are highly country focused. So essentially it will be country ownership, clear stakeholder role, and organizational setup and operational models will be aligned. So we have done a mapping. I'm sorry, this slide is very highly packed, but you can have a look at it at a later date, where we have done a real gap analysis of where the challenges remain. So there are areas in NTD where there's still lack of scientific understanding, diagnostics is weak, effective interventions are lacking in some NTDs. There is a need for more normative guidance and strengthening monitoring and evaluation, access and logistics, healthcare infrastructure and workforce needs to be improved. And the last one is the enablers, which is advocacy and funding, collaboration with multi-sectoral action. And of course, the bottom line of it is we need adequate capacity and awareness building right from the community level. So commonly, the accelerating progress of action is mainly to focus on effective diagnosis, make sure that there are NTD medicines and products and effective supply chain management. We are putting across robust monitoring and evaluation system and advocacy and funding. The cross-cutting approaches, as we mentioned earlier, includes referral management, especially we are linking with eye health, mental health, women and child health, disability management, and the overall community structures at the grassroots level. In terms of strategic input, we have the global vector control response, which drives at least 9 NTDs, which are vector-borne. Then there are linkage with other ministries, for example, with water supply and sanitation, agriculture, food safety, justice and social welfare, and infrastructure development like built environment, because we are also having a new department within WHO called urban health. And in this urban health, we are focusing on urban centers because 70% of the world population will be urban by 2030. So we really need a package targeting urban population. Then, of course, we are collaborating with other departments within WHO, the tuberculosis, HIV, TB, malaria, immunization, and other diseases, including nutrition, and of course, collaborating also with the education sector wherever possible, especially on soil transmitted helminths and so on. So the framework is both operating within the health system and non-health sector. We want a favorable political environment, highly focused on NTD epidemiology, and it would be a sustained coverage of NTD services within the universal health package, which we are trying to adopt at the country level. And so there will be high focus on countries, and prioritization will be there as we move forward. So the designing of the national, we are encouraging countries to develop a national NTD plan, which includes drafting targets and strategies. You can adopt your own targets. We are encouraging wider consultation with partners so that your plans can be revised. And actually, we really also need to think about the post-COVID world, because it gives you some levels of opportunity and there will be lack of funding, but we need to work together to bridge the gap and overcome the problems we have faced in the last 2 years. So the whole operating model and the culture to facilitate is highly based on the country ownership, where we hope to partner the academia, the pharmaceutical industry, multi-sectoral organizations wherever possible, disease experts, research institutions, and so on. But ultimately, it is the people and communities who are the focus. So we are planning, and a lot of tools are going to be rolled out at country level, especially to strengthen monitoring and evaluation, making sure that our budgets are aligned even with the non-governmental organizations working together to achieve our target, because we are really going to see that our targets are measurable and achievable. So basically, our application of the framework of the NTD roadmap is a sort of a sustainable working group, conduct stakeholder landscaping, assessing sustainability wherever possible, develop priorities, and embed priorities within the national health plan, basically, and implement and monitor them as and when needed. So basically, even our NTD roadmap will be monitored by the World Health Assembly once in 2 years. And so where we stand we have to report to the World Health Assembly. And in terms of monitoring and evaluation, we have a separate document under development, which is the monitoring and evaluating framework. And this includes 36 core indicators, 4 of which are overarching, 10 cross-cutting indicators, 22 disease-specific indicators, and 34 additional disease-specific indicators are there. So this is we have tried our best to bring indicators as minimum as possible, but because we are 20 diseases, we really need at least 1 indicator per disease. So this is the core of our monitoring compendium, which is currently being rolled out. Before I end, I really also want to touch on dengue, because I know in West Bengal is also affected by dengue. And why I'm saying this is it is one of the most neglected of the diseases, because it is a disease, as Lancet had said in a recent publication, it is the only communicable disease that has continued to increase. And it has increased over 600%, or say 6-fold since 2000 to 2019. And this is something which is alarming, and we really need to take some concerted steps. So even at the height of the COVID, since 2019 was a very bad dengue year, it affected almost 120 countries. Even at the height of COVID in 2020 and 2021, there are plenty of cases. And I have put this in red because our data collection is not complete. A lot of our activities are delayed due to the current crisis. But we hope that at the government level and at the grassroots level, dengue is effectively managed, because I know the threat is still there. And in many parts of India, we have got reports of dengue at the present time. So in terms of NTD, we have several documents, companion documents, which are basically the sustainability framework for countries. We have investment case, which we are developing. The monitoring and evaluation framework is already published. We have an updated strategy on integrating WASH with NTDs. There is also an NTD research and development blueprint under development, and also our linkage with One Health approach. There is a document currently under development, and we are also having the global vector control response, which we are also tuning to the new roadmap so that it makes it very easy at country level to work on multiple vector-borne NTDs and make sure that they are implemented as we move forward. So I think I stop there. Thank you very much again for giving me this opportunity. Over to you.
Thank you, sir, for the excellent deliberation. Now with this, we will request our next speaker, Dr. Pritam Roy, to please take forward their presentation. Thank you so much.
Pritam, you are not audible to us. You may unmute your mic.
Yeah, thank you, everybody. And it's a pleasure being invited in IIPSM Con 2021 West Bengal chapter. So thank you for giving us this opportunity for this presentation. And my topic will be from where Dr. Raman has ended. So he has nicely elaborated what are the diseases, what are the priorities at a global level, how we are monitoring. And I am just discussing the current disease priorities for India and a brief about those diseases and what we are working on. So basically, this is a disease of the poor. So what we say that this disease begins the life of 1 billion of people worldwide and threaten the health of millions more. So basically, those who are at poverty have a difficult and hard to reach areas they live with malnutrition, with low earnings. So majority of them are affected, but saying so, they are not the only who are affected. Even these entities are seen in peri-urban areas, and also some diseases are also seen in urban areas. So this is basically, though we call it disease of the poor, but it also affects all lives of people. So the different disease, so it may happen that it affects, and there is a more inclination to the rural, but it also affects the urban population also. So why we call these neglected tropical diseases? Because these are chronic communicable diseases, and that requires a tropical environment, and in these tropics they are seen in large scale. And immediately there is no global health security threat like COVID or something. So it doesn't come to a very big to media attention, but then these affects disproportionately the poor persons, and there is a stigma, there is a discrimination. So, and all those are the major factors. But hopefully these diseases can be controlled and prevented and possibly eliminated. And there are simple medicines and diagnostics, but it requires more research. So all this has given a concern of neglect, and so that's why we call this. So we have a lot of diseases of helminthic infection, protozoan infection, bacterial infection, viral infection, and recently what we call those snake bites has also been coming the neglected tropical disease domain. So there are a wide range of these disease domain here. Coming to Indian scenario, so majority of the states has some or more of these disease patterns. So of this leprosy, which affects nearly 60% of the global burden, the Kala-Jar or visceral leishmaniasis, that constitute of 50% of global burden, 40% of the global burden from filariasis. Dengue is almost there. Lot of helminth infestation, deworming programs. So these are the major entities that we currently work in India. So in 2017, there was a separately budget inclusion from 2018, and there is a specific budgetary inclusion for entities. So that's very important, and that shows the political commitment as well as financial envelope availability in India for entities exclusively. So one of the important diseases is Kala-Jar, or what we call visceral leishmaniasis, which is characterized by irregular bouts of fever. There will be weight loss. There is a swelling of abdomen, mainly because of the splenomegaly, and also anemia. But saying so that it's very classical, but even we get cases where the spleen is just palpable or mildly palpated. So swelling of abdomen, though we say it is a very classical or maybe a very late presentation, so mild splenomegaly, fever, that is are present. However, there are periods of afebrile periods are also there. So it's a chronic fever diseases more than 14 days duration, and there is intermediate periods of afebrile periods also. But why it is important? Because if a person is having VL or Kala-Azar and his or she is not diagnosed and then treated, then the chance of dying within 2 years is more than 95%. So it's a very fatal disease of a high case fatality rate. And that's why this intervention is very, very important, where we need to diagnose them and treat them. So usually the incubation period ranges from 4 months to 1 year, and there is a wide variation which may go even up to 2 years. And this fever is usually a continuous remittent or intermittent fever. And there is a these poor people sometimes are unaware about the fever and they go on working. So even they have a malnutrition, there is a weakness progressive, and these diseases are characteristics by infestation by opportunistic infection. So, and there is a progressive loss of appetite, pallor, weight. So these are the major features. With the splenomegaly, hepatomegaly, the skin becomes somewhat dry, thin, lusterless, and that's how the name came of this black fever, Kala-Azar. And there are serious complications because this patient dies mainly because of of upper respiratory tract infection or some GI bleeding manifestation or tuberculosis, diarrhea, and commonly we have an opportunistic infection of HIV and TB in this patient. But this test, we have a very easily rapid test available for this. So through this RK39 rapid diagnostic test, we can easily diagnose this case in the field with finger prick blood within 10 minutes. However, the most confirmatory test is, of course, splenic biopsy or bone marrow, where we demonstrate the LD bodies. But if a patient comes for the first time and all the clinical features are present and RK39 positive, we go for the treatment because that's more feasible and more practical solution to this problem. So any suspect of VL, we go for this test. Apart from that, we have this microscopic based of LD bodies. Currently, we are trying to have a PCR test available. So this will be most likely available from next year, where we can do PCR and get the diagnosis more rapidly in the field. The treatment is liposomal amphotericin B, and we, from the WHO, we provide to the Government of India donated medicine, Ambisome, which is made available free of cost to all the patients in government health facilities. And if there is any private case also, if they report the case to government or WHO, then also we provide this medicine free of cost to them. So basically the treatment is 10 milligram kg per body weight. It is a single intravenous infusion in 5% dextrose and is given slowly over 2 hours. And before that, we do a test dose for them. And the criteria for cure is the absence of the clinical signs, and we follow them after 1 month and 6 months. As such, this drug is very safe and can be given to even a pregnant patient after 12 weeks. So that's the current recommended treatment by WHO and Government of India for VL. Those who have HIV co-infected. So that's why HIV testing is mandatory before the VL. In that case, we give a treatment of 40 milligram per kg body weight instead of 10 milligram per kg body weight. And that is given in 10 divided dose. In each day, we give 4 milligram per kg body weight. The first 5 days, and then on 10th and 17th, 24th, 31st, and 38th days. So simultaneously, fractionated dose is given over a period of 10 days, and we need to give a higher dose for this medicine for those who are co-infected with HIV-VL. We have another disease manifestation which is called PKDL. So basically, that is a post-collagen dermal leishmaniasis. So it's usually occurs after 6 months to 2 years after cure or something. And nearly 10 to 15% patient don't give a definite history of having collagen before. So what happens in this case, there are hypopigmented patches and macules like this. So these types of patches arise in different parts of the bodies. And there are also nodules. So around the face, below, around the cheeks, and in the chin area, you can see these nodules. So these are like patches, which are very similar to leprosy, but the characteristics of like ear lobules get thickened, and the noses, there is a hypopigmented patch in face, in the body. But all these cases will give a positive report to RK39. So if we do a RK39 in a patient previously who had a collagen and now having patch, so they will give a positive RK39 test result. So that's how we can be sure that it is a PKDL. And another clinical differentiation from leprosy is that in leprosy, the patch will be not sensitive. So there is a loss of sensation of the patch. Whereas in PKDL, the sensation is intact. So that's, and if we do also slit skin biopsy of that, then we also can demonstrate that. And also we can do PCR based test from the from the skin sample. So these are the current diagnostics for the PKDL. And the treatment we give is the drug of choice now is the miltefosine. So it is available as 50 milligram of capsule given twice a day, and we continue it for 12 days. And if the patient's weight is less than 25 kg, then we give a single dose of 50 milligram miltefosine per day. So that's the treatment here. So coming to the program point of view, in India, it's the target is reducing the annual incidence of less than 1 per 10,000 population of blocks. That one means a new case or relapse case. So that's the target, annual target. And the major program component that we have is to bring those patients as early as possible under radar and give them a complete treatment. We have the integrated vector management where we do indoor residual spray with synthetic pyrethroids to the people who are living in collagen endemic villages. And we have this supervision and monitoring. We have to do the strengthening of capacity of the frontline workers, physicians, nursing persons. And from WHO side, we also do advocacy and communication, and also social mobilization is very important to be for this behavioral intervention. Coming to our next important disease, lymphatic filariasis. So basically, there are two things. One is asymptomatic filariasis and one is symptomatic. So asymptomatic is the initial phase when the patient is unaware actually that there is an infection. And this is the only stage where we can prevent the diseases. So if we give albendazole, DEC, and ivermectin, and then the patient doesn't become symptomatic. But the problem arises when the patient becomes symptomatic. Once the patient becomes symptomatic for filariasis, then there is no cure. So that's the major challenge of the diseases. And it has a two major manifestation. One is the acute and the chronic. So acute is the adenolymphrangitis and acute epidiomyocarditis, which we'll discuss. So these are the acute attacks where the legs or the hand become swollen, they become red, and there is a fever, and it's very painful. It's so much painful that actually hampers the patient lives. The patient can't even step, can't go to even toilet, and they're almost bedridden something. So this is the most distressing and disabling conditions, these acute attacks of fever, and which is known as the filarial fever, is very, very pathetic for the patient, what we should say. So usually the limbs are affected, and sometimes also the genitalia. And there are like fever, local pain, swelling, tenderness. And what we can see is the lymphedema of like the, and elephantiasis, and there is the early stage. If we see that it will become soft and pitting edema, and later on the whole skin change takes place and becomes thickened, more sclerosis, and become non-pitting. So basically there are 7 stages of lymphedema. So, and the features to be noted are like whether there are skin folds or not, whether there are nodules or knobs or there are not, whether there is a mosey appearance or not. So let's see. So in the stage 1, it is very a simple reversible swelling which goes away after midnight. And the skin are soft, smooth, and there is a slight pitting edema. In stage 2, their swelling becomes a non-reversible. So it becomes day or night, the swelling remains there. From stage 3, we get to have there are swellings which are not reversible, and we can see the skin folds are present, which are usually thickened, and there are entry lesions. These entry lesions means that within the fold of the fingers, there will be some fungal infection or some through where the bacterial and fungal infection takes place, and that are the major reasons for the acute attacks which takes place in this patient. So this is very important. In stage 4, what we do see is the swelling which are not reversible, and there are knobs or nodules, and the skin usually becomes thickened. There are shallow folds, and the entry lesions are also present. And at this period, the acute attacks, the filarial attacks, become more common, mainly because of this fungal and bacterial infection. The stage 5 is where there are deep folds are present, and it becomes so much constricted that it becomes very difficult to manage this patient. Stage 6 is something where this mosey appearance, the warty appearance appears in the limbs, and the skin becomes very thick, and there are deep folds. And the stage 7 is actually irreversible, and usually the patient becomes bedridden. So these are the clinical features of this disease. And why knowing these different stages is important? Because the management depends upon the stage of the diseases. So if it is in stage 1 and 2, usually we advocate for washing once, ideally at night. But after stage 3 and from the stage 5, if you see, it's ideally twice times. So because those are so many folds are there, so it needs to wash and make it clean. And then we need to do exercise for usually during the first 4 stage, the exercise like raising the limbs actually help. And like giving the prophylactic antibiotic has no role in the initial 3 stages, but after that, it usually helps. And stage 6 and 7 always needs prophylactic antibiotic creams, because otherwise during that time, the acute attacks become very, very common. So this is the overall area, the filariasis, where in India it is present. And from program point of view, we have 2 major interventions. One is the spread of, to stop this spread of infection through mass drug administration. That means the whole population at risk is given DEC, albendazole usually, and in certain districts, we are now starting with the ivermectin also. The second component, those who have already suffered, those who doesn't have the cure. So to alleviate their morbidity and preventing further disability, we have this MMDP component. So morbidity management and disability prevention. So those are the major components. So these are the 2 major components. And once an area which receives a continuous 5 years of mass drug administration, and if we see that the population at risk of that area has consumed 65% of the population, more than that, has consumed medicines. And if we do some night blood survey and check the microfilaria rate of the population, and if it is less than 1, then we go for the transmission assessment survey to show whether there is a break in this transmission or not. So this is what I was talking, the triple rug regimen, the new thing where we have introduced ivermectin along with the albendazole and DEC in the program in India. And usually in the field level, the doses are given So albendazole and DEC usually given based on the age criteria, whereas ivermectin is usually based on height criteria. So in the field, we use a dose pole like this. The frontline field workers carry a measuring tape or a dose pole like that. And based on the height, they decide that how many tablets should be given. So basically how this MDA works, it actually prevents the adult worm. So it partially damages and reduces the reproductive capability and kills and reduces the microfilaria in the bud, and thereby this prevents the transmission. Now we come to another neglected tropical disease, that is leprosy. So basically leprosy, what I say, is a disease of the skin manifestation. So there will be similar patches in the body, in the face, and nodules. And based on that, we divide it into two criteria, PB and MB. So if the patches are less than 5 or 5, we call it as a paucibacillary. If it is more than 6 and above, we call it as a multibacillary. And then also we try to demonstrate the nerve. If nerve is palpable and more than one nerve is palpable, we call it as a MB leprosy. And if we do smear and if it is positive at any time, then we call it as a MB. Besides, we need to have this grading of disability. We know leprosy causes a disability. Usually the disability takes place in hands and feet and also in eyes. So these are the three major areas which actually affect. So the hands, the feet, and the eyes, where this deformity for leprosy actually takes place. And for this, we have donated medicines called MDT. So it's based on MB or PB. We usually give a fixed dose combination of rifampicin, dapsone, and clofazimine. And for children, which is 10 to 14 years, so we give in a reduced, a smaller dose of medicine. And so that's basically the major changes in the program that we have. The new global strategy for leprosy is moving towards zero leprosy. So from this year to 2030, that's a global target. And what we are looking after is the 70% reduction in the annual number of new cases detected based on 2019 data, which is projected to 2020. So that will be the baseline data, and we will try to see in 2030 there is a 70% reduction in number of cases or not. And the deformity that we are talking about, that should be a 90% reduction in deformity. And the next is the 90% reduction in rate in per million children of new cases. So if we can reduce the leprosy among child cases, so then only we can actually be sure that the disease is going down. So that's very important, the child cases. And in the child cases, there should be zero deformity. So that's very important. So zero deformity among child cases, 90% reduction in rate in the children having leprosy, and overall 70% reduction in annual cases. So this is where usually most of the deformity are more than the desired level of 1 cases per million in India. So till leprosy, we can see there is a huge number of deformity present in India. So now to conclude the session, what are the missing links in the NTD's program? We don't know the real burden of the cases in certain diseases. So that's major challenges, because a lot of people, that is the neglected and disease of the poor, doesn't come. There is a less involvement of private network. So that's another. Then there are certain diagnostics and treatment delays. We have a paucity of real-time information and the impact of IEC activities. So this impact assessment are very less also. So what we are trying to see that let's explore the unexplored entities. So that's the most important and interesting part which I want to share with. Because these diseases, Kala-Azar, leprosy, we call it filariasis, we call it dengue, we call it snake bites. So these are very, very important, and we need to have these private physicians in rope. We need to rope in the labs, the district associations, and also the medical colleges. So that's very important. And I hope that through this IAPSM, we can actually rope in for reporting. We can have their support in MDA. We can have their support in adverse event reporting, in launching a program. These IAPSM members can be facilitators for capacity building, and IAPSM can also be give their association for branding also. And most importantly, in the research, evidence generation, and publications. We have seen that individual members come upon, but if as an association we come upon, then it becomes more tangible and more visible. So with this, I want to say thank you for giving us this opportunity. And I always think that if we want to go further, we need to go together. And so let's decide to move for the new move. So thank you. Thank you for giving us this opportunity, for sharing our views with you all in this conference. Thank you, everybody.
Thank you, Dr. Preetham, for the wonderful presentation and also the way forward for all our IAPSM members. And I am sure the Junior Brigade will jump in to this wonderful opportunity that you spoke of. Now, with this, I would request, like any participant, if they have any questions there, please feel free to ask the panelists in the chat box. And we now know that neglected tropical disease is a disease of poor, but it is not to be neglected. It is something which is of grave concern, and the slides just showed us what it can be if we keep on neglecting it. So with all this forward, let us hope and wish and pray that we can end the days of this trauma to the patients and really can look after them well. Thank you from our end for the wonderful efforts that WHO is doing.
Please wait. There are some questions addressed to me. Professor Arendra has asked a question: whether triple drug regimen is being used in West Bengal? If yes, in which district? How is it better than DEC?
This triple drug regimen is currently not in West Bengal. So it is going on in Uttar Pradesh, Maharashtra, in certain districts of Jharkhand and Bihar. Coming to the next question, that how it is better than DEC, the two drug. The first, it effectively reduces. So for two drugs, we need at least 5 years. But if we add the triple drug, then it comes to 2 years. So the microfilaria clearance rate is more if we add ivermectin. So that's number one benefit. Number two benefit is that sustenance of that becomes more. So that microfilaria clearance rate, that is more with this new drug. So sustenance of that, and ultimately we need a lesser time. So that's the benefit of the program.
Okay, there is another question to Dr. Raman Velayudhan. Maybe you can help this. What is the role and status of involvement of private sectors in implementation of National Program for Kala-Azar Elimination?
Well, this is something which basically you know very well that in Kala-Azar elimination, the foundation, the Bill and Melinda Gates Foundation, plays a huge role, both in Bihar as well as in other 3 countries where we are aiming for the elimination. Now, in addition to that, at the local level, there are NGOs who are also putting an effort into it. But what we wanted to highlight today is that we really need more people. We really need more people in terms of enhancing monitoring and also to greater advocacy in the local language, for example, at the grassroots level, if you are to achieve full elimination and if we want to sustain it. So this is the main message we want to convey. There are groups involved, but we still need more. Over to you.
Dr. Niranjana, you
Yes.
can ask Chairperson